Our next session, I just would like to introduce my brother from another mother, Dr. Christopher Ames. We've been working together like since 2007. It's been 15 years, an amazing journey. And he's very passionate about research and future of the spine surgeries. He's done so much work on AI, predictive modeling. And now his new passion is the biomarkers and telomeres, and he's going to talk about biomarkers and the risk assessment of spine surgery.
I think Lee Tan's was louder, actually. Yeah, it's a pleasure to talk about some of our work, and it's really an honor for us also to have some of our PAs and NPs and research students here. And I'm going to try to tell the data story. You've received pieces of it that were described quite well by some of the other speakers who just talked about AI and value. But I'm going to try to bring it all together and then at the end kind of show you where at least I think we are at the point of the spear. We still have a lot of work to do. I do have a very significant disclosure in that I work as the lead clinician data person for Medtronic across all their capital platforms and software. So I don't think any of that will really affect this talk, but that is a significant disclosure I have. In case I run out of time, these are the most updated papers that we have on some of the epigenetic clocks and biomarkers. If you have an interest, you can look these up, and Sig showed the one from before we just published. So I want to start from a very basic level. We have a lot of younger surgeons here who are thinking about research projects. And one of my real pet peeves is that oftentimes research in spine surgery is really driven by what's. The classic example to me is like lateral interbody fusion in the curve apex at 2.3 or 3.4, where we're designing all kinds of different ways to approach that and not taking a step back and thinking about what really are our problems. Hanjo and Bob talked about some of this today and cost savings and all this. Those are real problems. And I'll show you some of the other real problems in a moment. But a lot of the innovation that goes on is around made-up problems, where we're developing solutions where problems really don't exist. So I really love this book by Simon Sinek about starting with why. Every time we come up with a new research project, certainly in our groups, we try to think about what is the question that we're trying to address. What is the problem? Not what does the data show and what paper can we put out, but what is the real deep-seated problem that we're encountering in our daily life as a spinal deformity surgeon. So here's one problem. Essentially, we're surgical geriatricians, and some of this data was shown before. I didn't realize this when I started my career in adult deformity surgery, but really the patient population we're treating, they're geriatric. Many of these patients are 70, even 80 years old. We've gotten better, and Vdara and I have been working together for years and years, and all the other surgeons at our institutions work together now to be able to do these operations more safely. But we can't change the innate physiology of the patient. We're still operating on someone who has senescent cells, who doesn't heal well, and who can't tolerate a lot of volume variability. And so we published this paper in Spine last year, and it was essentially looking at spine surgery like a manufacturing process. And the first was to quantify failure in spine surgery, literally the topic of the article we wrote in Spine. I don't know, Patrick, I think you were on that paper, was failure in adult deformity surgery. And what does the literature show? How bad are we? Essentially, we look at the assembly line, we're producing spines. What proportion of them are coming off the line and they're not good? They have to be redone. If we look very critically at our data in the International Spine Study Group, we see we've gotten better in certain areas, like for example in operative complications, but we haven't gotten better at all really in mechanical complications like PJF. And if you look at the needle over the last 5 years, we haven't gotten much better really in any area. We've reached kind of a plateau of improvement because we're concentrating very much on the surgical aspects of the case, and we haven't been focused enough on the patient substrate. This produces this very critical problem, which is a comparative problem against other specialties as well. We have a 20% revision rate on average in adult deformity surgery. We did a huge meta-analysis. We looked at every reoperation paper in the literature as part of our failure review. And when you compare this to arthroplasty, for example, who competes for dollars in the musculoskeletal service line, we see that as spine surgeons, we're really doing horribly. Arthroplasty and cardiac stents, cancer, they're all doing a better job in terms of having lasting benefits for the patient. And so we need to change, as I mentioned, from a focus really on devices and things we put in patients to a much greater focus on the substrate of the patient themselves. Some of this involves our partners in industry who need to change their focus from monetization of implants to potentially monetization of data. And I'll talk about that at the end of the talk or maybe in one of the questions about the future there. But really, we're going to see a lot of the medical device companies really change their data focus. Medtronic, for example, their chief technology officer, his last job was not in medical device. His last job was at Amazon. And we're going to see more and more of that going on across medical device. These companies are going to be making data platforms and software to inform us to improve the care of our patient. And you're going to see much less iterative improvement with more pedicle screw systems in the future. But that involves a lot of transition in terms of learning how to monetize those things. And I'll tell you right now, working pretty intimately with one of those companies, that's really a strategy that has to be refined. And that's where I was asking Bob about that. What if in the future we could differentiate patients on the substrate level before we ever touch the patient in a much more refined way? So that scatter plot that you see represents every patient in the North American and European database in terms of their outcomes. And you can see some did extremely well, some immediately deteriorated, some deteriorated over time, some took a long time to get better and eventually got better. But we can't tell those patients apart on the front end when they're sitting in front of us in clinic for the most part. Our judgment can't differentiate them, and we need to develop tools in order to do that. It's interesting, though, if you look at the benchmark sites, everyone's like, especially some of the more prominent surgeons, they think, oh, if the patient only came to me, I would have made a really significant difference in their outcome. When we compared outcomes across the registry, the change in ODI that was related to the surgeon was only 2%. So as great as we think we are, probably once we reach a certain level, we're not moving the needle as surgeons, and we need to look, again, at the substrate. We can learn a lot from looking at what's been done in cancer over the last several decades. They've made tremendous strides in telling patients apart on the front end. When they design clinical trials, they do receptor analysis, they do genetic analysis of the tumors, and then they determine in which patient is this intervention likely to have the greatest impact before they perform the intervention, before they perform the surgery, the chemotherapeutic trial. So the modern reality of cancer care is this. It's gone from looking at histology under the microscope and saying, for example, that's a chordoma, that's a conventional chordoma. That's something we also treat at our center in fairly high volume. They look very similar under the microscope, and yet some chordomas have very aggressive behavior, some don't have very aggressive behavior. And now every chordoma at our institution that we operate on gets a 500 gene panel. It's called the UCSF 500 panel. And many times they uncover therapeutic opportunities within this genetic panel for chordoma that come from breast cancer, prostate cancer, colon cancer. They have other mutations that they weren't expecting. And I think in the future, we're going to be doing more and more of this with our deformity patients, and I'll show you how we're going to start to apply some of that. So some of the lowest hanging fruit, as I was discussing before, is the idea of patient clustering. So if you just think about how the surgeon looks at the patient, we process a variety of different data points, and some of the best studies on human judgment show that we can process really at most 5 variables at once. So we can't really integrate and calculate better than about 5 variables. But of course, if you just look at the general variables that we consider important on the patient, it's far more than 5, and it's probably closer to 25, 50, 75 if we really want to paint a very accurate, detailed data portrait of the patient. Well, we built a clustering analysis years ago. This is now probably 5 or 6 years out in combination with the European Spine Study Group, where we allowed the machine to go in using unsupervised learning and cluster the patients. And so that kind of flower plot you see there, it represents, every dot represents a patient in the database. And not only did the computer say, essentially, you guys have 3 different types of patients on the whole, But it also allows you to do this. It creates a nearest neighbor analysis. So it says, these are the patients most similar to the patient in front of you, and this is how they were treated and around the world. So you could look at, if you apply this to pediatrics, you could say, this is how Lindsay treated the patient, this is how Dave treated the patient, this is how Ibrahim Obeid in Bordeaux treated a very similar pattern of the patients, and this is how they did. You can generate a risk-benefit equation for the patient in real time, and very importantly, you can decide, based upon the cluster, how that patient's likely to do and whether surgery really makes sense for the patient. It's crazy. In the past, we based our adult deformity classification on an R-squared value of somewhere between 0.1 and 0.3, and that was how we were differentiating the patients. That wasn't giving us any risk and benefit information at all, and that's really what surgeons want to know. So clustering analysis based on more than 100 variables allows us to do something like this, where you can say this is this patient type matched with this surgery type, all done by the computer. We didn't tell the computer any a priori information, and you can match that to the SRS-22 improvement, the ODI improvement, and the major complication risk. It also allows us to do this. I saw a case like this once. Like, I sit there sometimes and think, I'm trying to remember I did a case like this a few years ago or something like that. Now, real time in the database, this is not just imagine, this is something that the companies are working on that exists. It just hasn't gone through the FDA approval process. They can pull out similar patients out of the databases. So just in the last year, the only company in the precision medicine space that makes rods right now, although pretty soon there are going to be 2 or 3 or 4 other competitors, they added about 10,000 patients in a year. So when you think about where is the real data going to be in the future to create these software tools, it's probably not going to be as much in the registries anymore. Unfortunately, that's just the reality. It's going to be with industry. It's going to be with some of the vendors that you see out there in the hallway. They're going to be able to pull out cases from databases of 25,000 x-rays, 50,000, 100,000 x-rays, and it's just going to accelerate. So you can sit there in the future, your fellow who trained with you, who is now opening their first clinic, when they see a patient, probably within the next 2 years, they're going to be able to pull up a similar patient matching algorithm and look at how that patient was treated all around the world. They might be thinking, I'm going to stop at L2. If they look it up and they see no other surgeon stopped at L2 in that patient, they all stopped at T4, that's probably going to tell them something very significant about their management of the patient. One of the goals of using data and variables is to try to make the best surgeons better. So it's fairly lower hanging fruit to make surgeons that are inexperienced better by giving them tools like similar patient matching. But how do you make Vdara or Sig or Dave like a better surgeon? That to me is one of the real challenges. And I think they'd be the first to admit that their problem is really their perspective and their bias. Some surgeons are biased to be more aggressive. Some surgeons are biased to be not as aggressive, to do anterior surgery, to do posterior surgery. These are exactly the same size, by the way. I had my son measure these. These are exactly the same size. I still can't wrap my head around it. But when I saw that, I was like, gosh, when I look at x-rays or look at people or patients, I don't know what I'm doing. Another really good book, it seems like this is almost like a book club now between Sig's talk and my talk, but another good Kahneman book is Noise. And it's about the bias and noise in systems. And that's one area where I've had conversations about this with Dr. Lenke. He admits very well that he has certain inherent biases, and probably all of his cases are biased in certain direction, even the way he plans the case. And you're not going to overcome that without utilizing technology. And let me show you an example of human bias. So this is a risk calculator that we developed out of our existing variable systems. And we compared what the machines predicted and what the surgeons predicted for the patient. And let me just show you the surgeon survey that we sent around as part of this study. So we said to all the surgeons in ISSG and ESSG, estimate, and we gave them all the x-rays, we gave them all the variables that surgeons typically look at, estimate the 2-year complication risk. And look at case 7. One surgeon said the 2-year risk is 1, and one surgeon said the 2-year complication risk is 100%. So that's not very helpful when you go to counsel patients or you go to, provide information or consulting to your residents or ex-fellows who call you. If you're that way off or with such a wide range, that's not going to be very effective in terms of creating tools that are going to guide better care. So about 5 or 6 years ago, we put together the ISSG and ESSG registry with our friend from Police in the European group, and we developed a predictive calculator. So someone showed some of these slides earlier. Basically, we put in demographic information, we put in radiographic information, and information from the disability scores as independently predictive variables. Where did we get all these? This is just what we had in our database. So we built with what we had, and we developed predictive models of complication that varied in accuracy from 65 to 80%, depending upon what population you looked at and what time point you looked at. And one of the very important differentiating factors between the machines and the humans is humans were designed to detect immediate threat. So that was like where our evolution came from. If you read *Sapiens* or some of these books by Yuval Harari about our evolutionary propensities, we were very good at detecting immediate threat. That's why we survived. So our ancestors all did a good job. We're all here today. They all detected the saber-toothed tiger around the cave. They weren't going to go around that corner. They knew there was an immediate threat. But where humans are very poor is at detecting delayed threats. Like 1, 2, 3 years down the line, we can't process that kind of information, probably due to the way we evolved evolutionarily. We also can predict outcome, and this is really very important for patient counseling because you can't integrate well the decision-making process unless you also couple outcome with risk. It's always a risk-benefit equation. And these calculations, these accuracies varied from, again, about 65 to even 85% for some of the functional variables, and they weren't quite as accurate for some of the mental variables, which is, just kind of just what we would think. What can you do with this information? Well, you can, if you're the healthcare system of Spain or you're the your NHS or probably Medicare in the future, you can draw a line and you can say now that we can predict accurately risk of major complication, we can predict the likelihood of MCID. For our population, we can decide how much surgery we're going to pay for. And you can, based upon your resources available to your economy, you can draw this filter in any different ways. If you draw it in the US, a 50-50 filter, you could save the US about $500 million just in direct cost for spend in adult deformity surgery for surgery that didn't work. So this is where we were. I told you this would be in the context of a story. This is where we've been for several years. And why have we been here for several years? Because we got some criticism from the SRS. They said, okay, you guys have to add a lot more patients. We were at about 2,500 patients, and they said this is not predictive, even though number of patients doesn't necessarily make things more accurate. So we added 500 patients, and we waited another year, we added another 500 patients. We were not getting more accurate. We were exactly the same with the addition of more and more patients. So what that told us was we were missing variables. We were not looking at all the right things to make our models more accurate, or it might mean that it's just a chaotic system. But I prefer to think of it like we're missing some variables in the equation. So what are we missing? Well, the SRS wanted us to say we're missing scores, like easy to access scoring point systems, but we already have those. We already have frailty scores. They also really like R-squared. It's always on the podium at the SRS and NAS. Why is that? Because they want everyone to feel comfortable writing up their series and doing, statistical analysis. But unfortunately, if you look in Lancet, New England Journal, Journal of Clinical Oncology, they've all moved beyond that. You're not going to get papers into those journals without a very deep, at least multivariate analysis these days. And we need to do a better job in spine surgery. So you can't do it based upon looking at one variable, even sarcopenia and some of the new variables. You have to take everything together. The surgeon, the patient's expectations, the patient's opiate history. So that means it has to be a predictive model, and it has to be done where the data is. It's not like everyone can produce this kind of work. It's either going to be done by the registries, or it's going to be done by the companies in the future who are going to have most of the data. That's just how it is. Otherwise, you're going to continue to publish R-squared. And it's kind of an inconvenient truth, but that's where we are. So let's look at a few things. One of the ideas was to apply frailty, an easy point scoring system. Mike Kelly did great work last year that showed that if you want to apply pure frailty, which people consider to be Edmonton, you apply that to our database. It only applied to 4% of patients. Only 4% actually qualified as Edmonton frail. So we developed the Adult Spinal Deformity Frailty Index, but what is that? That's just a scoring system that's associated with complication. This was shown the other day in someone else's talk. It was essentially a predictive review of systems. It provided useful information and it correlated to risk of major complication. But this is the slide I want you to pay attention to, and this is the one that called up some questions in our mind. It was interesting to us that frailty really was associated with all kinds of different complications. And why would that be? Because probably frailty, in a way, measures senescence. It's probably a major measurement tool for the degree of senescence that someone's undergoing, their sarcopenia, their physiologic ability to heal, their genetic age potentially. So we decided that although we continue to add every year, the variables that we have, that in terms of the point of the spear with ESSG and UCSF and ISSG, we were going to take a step back and go on a new variable hunt. And now I want to show you the new variables that we're looking at. And they're going to span a whole lot of different things, some of which we've seen already today. The first one is moving beyond BMI. So we need to move on to measures of sarcopenia. Actually, other fields have moved beyond this a long time ago. They've moved to actual measurement of intra to extracellular water, because we know that patient on the right who actually has good muscle bulk, has horrible and is a normal BMI or even heavy, actually has really poor muscle quality. So just measuring someone's BMI doesn't work. And we now use an InBody 970 machine in the clinic. It's a clinical grade sarcopenic assessment. It does intra to extracellular water, and there are numerous publications showing that ratio is linked to complications in general surgery and other aspects, but it's coming very late to spine surgery. So I really like to talk earlier on sarcopenic classification. This is one part of the equation. It's essentially calculating what the patient's muscle quality is in a really well datafied and validated way. Another thing that we need to consider is that the metrics that we're using to assess these patients in terms of our disability phenotypes are way off. All these self-reported measures, if you look at the relationship of SRS activity to 4-meter walk time, there's no relationship at all. So what they're saying is that whether they can walk well, it has nothing to do with whether they can walk well. So all the models that we previously worked on that predicted SRS-22 physical activity score, I'm not sure what that's really telling us. It's telling us that maybe we can predict how the patients say they're going to walk, but it's not actually telling us how the patients walk. Another measurement we now do on every patient is grip strength. It's been associated with age in many studies. It's associated with muscle quality. And this was really interesting. This can be altered through interventions that have nothing to do with the neck or actually training the grip. When we operated on patients and did an adult deformity surgery, we actually saw that more than half of them actually had improvement in their grip strength. So just fixing their backs and putting them through a rehabilitation process and making them more active had some deep physiologic impact on their phenotype, on their sarcopenic phenotype. And these were not patients that had myelopathy or anything else like that. The other area that we're really appreciating is that the equation that we used to have between sagittal plane and outcome is also way off. Look at this data. This was a hot potato political issue in our study group that for years and years they didn't want to publish. And we just got favorable reviews at JNS Spine. But if you look at the 2-year relationship post-op of ODI versus SVA, the R-squared is 0.05. The top variables, and I'll just tell a quick true story about prediction. We asked our scientist who did all our predictive models, he was an economist, just like Daniel Kahneman sort of, and we said, why don't you predict the best alignment for the patient that maximizes their outcome? This is when we were in the throes of doing all the modeling. And he was normally getting back to us really quickly. He's a very industrious guy. He came back to us like a month later, and he's like, I tried every single model. I can't do it. And we said, well, why can't you do it? He's like, because it doesn't matter. It's actually not a top predictor at all. And the pre-op SVA was like number 12 in post-op outcome, and the rest of them were completely meaningless. What do you think was the top predictor of someone's outcome? Any idea? What do you think? Well, we didn't have social determinants of health, but it was actually their pre-op state. It was how bad off they were before surgery that predicted the strongest how much they were going to improve. And really, sagittal plane, the post-op alignment of the sagittal plane really had nothing to do with it. Another just interesting way to look at the confounding nature of some of the variables we'd been considering very important. If you look at the 3-meter walk test, leg pain makes sense. It was one of the stronger predictors, but cognitive score was actually the strongest predictor of how fast or how well somebody was going to walk. So it shows you that you can't just analyze these variables in isolation. Like even cognitive impairment has an impact on physical activity in a way that maybe was not obvious to you. So about 3 months ago or so, 4 months ago, we started doing gait analysis using the Movella, and we now quantify essentially the dynamic nature of every patient's gait pre and post-op. And this becomes a fully datafied process. We also look at their extensor muscle integrity. So this may have some impact in terms of speed and muscle integrity on their development of PJF. We can do post-op gait assessment. Everything before the elephant in the room had been all static assessments of patients, usually one pre-op time point to one post-op time point. But these are not static structures. These are dynamic structures. And so we came to the conclusion we were leaving a lot of predictive variables on the table by only looking at static numbers and static data. So to finish up, I want to move into the biomarker area. The first predictive biomarker, and I vividly recall the discussion probably 6 years ago now when we were designing our new data set. And I'd read a paper in Nature about the aging process, and they one aspect of patients that they considered important in aging was they call them the inflammators. Some patients become more inflamed as they age, and I suggested we include CRP and ESR in our data set. And sure enough, we found that CRP, their preoperative inflammatory state, even separated from any infection. This is maybe some of them had some sort of lingering infection or something from a prior surgery. But the vast majority, it was just their inflammatory state that was predictive. Makes sense, right? Because inflammators have more cardiovascular disease, their bone biology is off, they don't heal bone well, they don't go through a normal inflammatory phase of bone healing. And then, as was mentioned before, the other aspect we're actively looking at, and this is through a lot of software partnerships, is with ESSG, is the ability to build in radiomic sarcopenic assessment. So through either abdominal CT or even spine CT, there are numerous algorithms that have been published in the radiomics literature for years that do a radiomic assessment of fatty infiltration of the muscles. And this can give you an idea not only of what their sarcopenic state is, but probably also a patient in a terminal state of senescence and myastheosis who can't be helped. Like this patient, just like the end-stage Parkinson's patient, will not have the ability to control their spine post-op because their muscles are just too weak. And this is probably a patient that shouldn't be operated on. This has been shown to be impactful in tumor survival and tumor outcome, and will be coming soon, I'm sure, to data hubs in the future for sarcopenic assessment for spine. Finally, for aging-specific biomarkers, we were lucky at my institution to have Elizabeth Blackburn, who discovered telomeres. We went to her and we said, would you mind collaborating with us on a study on telomeres? And she said, absolutely not, I don't have time for that crap. But I will give you my top technician, he'll run your telomere length. And she did. And what we found was that telomeres were actually, the telomere length was our strongest predictive variable in terms of early complication post-op. And this was the Hibbs Award paper in 2021. So we really thought that was a pilot study, and we talked to more and more experts in the aging field, and they said, you know what you guys really need to do is move on to more epigenetics. Epigenetic aging clocks are where really all of the senescence literature is going toward. Why? Because it's less variable. So telomere length is like a highly variable test. If you redo it a lot, you'll see like different variations, and they don't trust it as much as they trust epigenetics. Epigenetics is more like hemoglobin A1C. It has less like, month to month or week to week variability. So we moved on to epigenetics, especially this clock, which is called Dunedin pace. What's interesting about Dunedin pace is it's not a biological age calculation. Dunedin pace was developed from a twin study done in New Zealand. It's actually called Dunedin, New Zealand. That's where the name comes from. And they followed more than 1,000, or not twins, but 1,000 patients for 50 years. And they continue to follow them in terms of what comorbidities they're developing. What sets Dunedin pace apart is it's actually the instantaneous pace of aging. So it's how quickly are you aging right this minute. It's not your biological age. So probably your physiologic state is your biological age plus your pace of aging. That's probably really where your frailty lies. This was interesting because for the first time, we showed that an epigenetic aging marker, your pace of aging, your current pace of aging, was correlated to the ASD frailty index. And this is where we are today. For the first time, we really identified one of the biological markers of frailty. And what's interesting about this is it's an aging biomarker. It's been shown to be responsive to caloric restriction, which is kind of like now their sort of gold standard for whether something is responsive to anti-aging intervention, because caloric restriction has been proven to be so effective as an anti-aging therapy. It was responsive to that. And in our patients, we found that patients that had a higher Dunedin pace, they were actually, the patients that had complications were aging 13 months a year versus 12 months a year for the normal patients. So we linked this for the first time to risk of major complication as well. This epigenetic score is not equal to disability status, so we're measuring something independent of that. And we are now moving on from this to metabolomics. So I'll show you, there's several good papers that are starting to correlate various blood chemistry markers to physiologic scores. One is the time to get up and go, has been linked, you can see from the paper, linked to like tryptophan, and then the Edmonton frailty score has been linked to other chemical biomarkers. Bob Eastlack is heading up the senescence SRS focus group, which is focused on trying to determine what are going to be the best of these chemical biomarkers to start to collect in the adult deformity patient. But it's really interesting to me that cognitive score measured by MoCA, Edmonton frailty score, and time get up and go all had certain chemical maps, essentially, that were linked to those in this PNAS paper. And these can be trained to various measures such as grip strength, et cetera. So it's going to be a very interesting time over the next 10 years as we see more and more of these physical phenotypes linked to chemical phenotypes and epigenetic aging markers. And our goal is essentially to expand our data footprint. So if I come back and give this talk in 5 years, I hope I'll show you different clusters that are informed by Dunedin pace and informed by various chemical maps of the patient, as well as the patient's dynamic gait assessments and their sarcopenia as measured by the InBody 970. And finally, to quote Donald Rumsfeld, we realized that there are a lot of unknown unknowns that we're still missing. And so we entered into, about a year ago, a tissue collection effort that is being expanded to include OC, WashU, Hopkins, and Rady, and ESSG. And we now have about 170 specimen. We started about 8 months ago, where we collect bone marrow, fat, muscle, iliac bone, disc, synovium, spinal bone, and blood on every patient. We collect post-op drain fluid, we collect post-op urine, we collect saliva on every patient for MIS and deformity. so that we can look at the granular spread of the data across the different procedures, start to measure the physiologic impact of injury of these bigger operations, look at differential response to tissue injury, and have a data set that we can use to look at different bone biology, to really define for the first part, to datafy the bone, the substrate effects of the bone over time. And you can build tissue-specific aging clocks once you have this sort of tissue-specific data. And finally, this is what it's all going to look like. It's all going to be based around like preoperative planning, radiographic planning, probably gait assessment, digital phenotyping, tissue-specific markers. And then this is the key component of the process. It's all going to be constantly updated. The software is going to be improved with more and more variables, more and more patients to improve the care of the patients. It's a process improvement that's going to occur over the next generation. And unfortunately, the study groups can't grow as quickly as some of these industry databases. So I think we're going to see a shift about where the data really is. Industry is not going to be able to test the new variables very well because they don't want to spend money on things that might not pan out. But if you're looking at the variables we already know are important that they're including in the data sets, they're going to grow at a rate and across the world at a rate that we can't compete with as the SRS or as an individual registry. Thanks very much.